So, okay.
So for some reason I lost my mouse. Where'd you go? All right, there we go. Well, evening. So welcome. So this evening we're going to be talking about nutrition, just titled A Collaborative Nutrition Approach. I'm going to give a little bit of an introduction to myself first, personally and professionally, and then we'll jump into this evening's topic. I always like to give an intro to me so that I'm just not, obviously, just a talking head of someone you've never met before. So I'm originally from New Orleans, likely where my passion for everything food and nutrition originally stemmed from. Living in a community, a society that's really inundated with chronic disease, particularly obesity, diabetes, hypertension, right? Those lifestyle chronic diseases, especially in the South, and a lot of it being driven by what people eat. So I think that's really where a lot of that passion probably originated from. This is my wife, Katie. She's also a physical therapist. She practices on the other end of the spectrum, though, in pediatrics, where I spend most of my time with the geriatric population. We are diehard LSU Tigers and Saints fans. That's where we spend most of our fall is rooting for them. And then outside of that, we love to travel. So for us, it's really just kind of experiencing other cultures, traditions, and really for me, it's experiencing other cuisine and kind of seeing what the food is that other people eat around the world. So we typically try and do an international trip once a year. The most recent, about a month ago, that bottom right picture, we were in Peru visiting Machu Picchu, like I said, about a month ago. So Peruvian food is pretty good. This is my daughter, Madison. You're probably going to start picking up some audio at some point in the back. So this is my disclaimer of I have a 2-year-old and it's a weekday and she is not sleeping yet. So just to kind of give you a heads up on that. But she is our, I guess you would term, pandemic baby. So she was born, back in the heat of the pandemic, and she just turned 2 this past May. And then that's our forever puppy, Rue. So that's me personally. Professionally, I am both a registered dietitian and a physical therapist. My professional journey started within the realm of dietetics and nutrition. Again, growing up in New Orleans, having that passion for food, that's where that initial path was going. And with the thought that what people ate had a significant effect on their risk of chronic disease. But what I quickly learned, there was more to it than what a person ate. There was a movement component to it, an exercise component to that. So I started doing an exercise science degree, actually simultaneously with my dietetics degree, to kind of see where I would end up. Would I be more towards the nutrition? Would I be more towards that movement? I ended up graduating in dietetics, and at that point knew I was going to go into physical therapy. The disheartening thing is I left one profession that only looked at what people ate, and I found myself in another profession that only looked at how people moved, movement dysfunction, pain, functional disability, etc. So it was disheartening. So after getting out of PT school, my wife and I had done some travel therapy for a bit, but then actually left the field of physical therapy for about 8 months and went back and completed my dietetic internship in order to sit for boards. So since then, it's kind of been, again, trying to combine movement and nutrition, really trying to be a partner in health for many people. My ultimate goal as an individual clinician is to try and keep people out of the healthcare system, again, with kind of the focus of movement and nutrition. So I'm in South Carolina. So I still find myself living in, kind of that diabetic belt of the country, living in those communities that are high in prevalence of diabetes, hypertension, obesity, etc. My company, Fuel Physio, does a lot of various things: education, consulting, Con Ed. Professionally, though, for me recently, I've actually segued into a lot of teaching. So I serve as adjunct faculty for several universities, and will actually be transitioning into full-time academia next year. I do serve as chair of APT's Health Promotion and Wellness Council as well. and I've been with that council for the past 4 years since it became a council. And then just like Eva, I also serve as a delegate for the state of South Carolina. So it's kind of me professionally, but yeah. So just to kind of give you a little bit of background, a little bit of perspective on where things come from that we'll kind of be rolling into. The objectives you likely already have. This evening is going to be relatively simple, and it's going to go by relatively quick as well. It's a lot of information. I've tried to just really cram into, the hour and a half that we have together, the hour and 20 minutes really that we've got left. Pulling out from courses that I typically teach that are a day so or even longer. But again, trying to pull out some of the highlights, some of the basics, from a clinician's perspective, what's good to know, and from a physical therapist perspective, an occupational therapist perspective, professionally, what can actually be done by us. So again, the viewpoint from here is primarily from me as a PT, but it's a very similar approach as if you were an occupational therapist, an exercise physiologist, a trainer, etc. Those conversations we have, the extent that you implement it in the practice, those limitations or distinguishing factors that dictate what you can and cannot do, it's going to be relatively similar for most of us. Okay, and then the good thing as far as the design of the company you work for is you have a dietitian on staff too. So we'll kind of go through screening, identifying really when those needs should technically kind of push off to that teammate, kind of partner up. So we're going to start with just a basic, Webster Dictionary definition of nutrition. I think for some, when they use the word nutrition, when they use the word diet, it's thrown around relatively easy without the understanding that it is a very broad term that encompasses a lot of information. When you look at nutrition, it's everything behind a human being consuming food, digesting food, metabolizing its nutrients, and then utilizing those nutrients. And then it also includes how it affects the human body's ability to maintain its health, to recover. Right? That's what nutrition does. But the interesting fact is there's a lot of stuff that influences a person's nutrition. Right? There are things that influence the science of nutrition for an individual. And it's things that I term determinants of healthy eating. And it's things that we often don't talk about. And I think clinically, these are the conversations we need to be having. What we'll look at this afternoon is, yes, here's some basics on nutrition. Here's how it could potentially affect health and outcomes. This is why it's important. But people know they need to eat healthier. People know they should probably eat more fruits and vegetables. People know, I apologize. People know that they need more protein, right? We get it, okay? So just telling people that information over and over again, it doesn't really do anything. It's trying to find out, what are those underlying barriers? What are those determinants of healthy eating? What is the why behind that person's decision? Or what's the why behind the access issue that they may be having? So it's those influencers. And as I said, things I term determinants of healthy eating, and we'll look at them a little bit later on, but I think that's where we really need to be having a lot of our conversation. Okay, yes, it's important to know the basics, sometimes tying in that information and educating, to its importance, but really addressing those underlying barriers and those underlying determinants. Now, when looking at the science of nutrition, the simple part coming out the gate is we have to eat, right? We've got to consume the food day to day. And typically for Norm, we have to consume it by mouth. Right? You can't just plug into it. You can't just hold it. You can't just think about it. You actually have to physically eat it. But when it comes to digestion, okay, that process of taking in food and breaking it down, it doesn't necessarily matter where that food comes from, because we're likely going to chew it the same, swallow it the same. Our body's going to start to break it down the same. That digestion process is going to be very similar regardless of where it comes from. Now, the nuance kicks in when you start looking at metabolism and the composition of that food. Well, what was there? Because if you had the meal at the diner and it was very high fat, right, or maybe high processed carbohydrates, yes, after those things are broken down and the body starts to metabolize and utilize nutrients, it's going to be different. But starting out in the consumption of food, doesn't really matter where it comes from. Right? So I do think, though, it's important to kind of look at those components of the digestive system and really just kind of an awareness to, if you're dealing with a patient or a client who has some type of disease state or condition dysfunction that's affecting an organ of the digestive system, okay? Difficulty chewing and swallowing, poor dentition, okay? Looking at that oral cavity, maybe dealing with someone that's had been diagnosed with gastroparesis or has had a portion of their intestines removed. Okay? If there is a component of the digestive system that's affected, that entire breakdown, the initiation of nutrition is going to potentially be affected, and therefore their nutritional status could be impaired. The same thing goes for those accessory organs, those things that kind of facilitate the breakdown of food substances. If you've got impairment or conditions to those as well, there's a potential that nutritional status could be impacted. And with that, there's a lot of potential for error, whether or not it is a disease state affecting an organ, or whether or not it is a digestive error that someone's born with, or that happens generally over time. You could take an individual who is lactose intolerant, where they're missing the lactase enzyme. It's disrupting their digestive process. They're not able to break down that disaccharide because they're just simply missing an enzyme. Or it could just be those biological changes that happen over time. It becomes more and more difficult to chew and swallow. It becomes more and more difficult for the body to process and push food along the digestive system over time as things start to slow down. But it just happens. Or you could have that situation where there's a disruption to the digestive environment. Okay? Taking multiple medications, taking those antibiotics for a long period of time could potentially start to mess things up. Now, when that food substance starts to break down and those nutrients enter into the bloodstream, that's where things start to get even more complex. And when you start entering into metabolism, where those nutrients can then jump into multiple different pathways. And with jumping into those multiple pathways, all they're doing is undergoing various chemical reactions where there's an exchange of energy, where the body's either building something and using energy, or it's breaking something down and releasing energy. That's all metabolism is. It's just that transfer of energy. And it's because energy can neither be created nor destroyed. But that's really what metabolism is. But that metabolism for an individual is going to vary. Okay? It's going to vary based on age, gender, activity level. And then that's when it starts to vary based on the composition of the food that's being eaten. Because if you provide the body with an abundance of X, Y, and Z, okay, compared to an abundance of another X, Y, and Z, the body's going to deal with it very differently. So just like with digestion, there's a lot of potential for metabolic disorder as well, where there's an abnormality in those chemical reactions. And the body has a tendency to end up with too little or too much of a substance because, the reaction and that transfer of energy is not occurring appropriately. It could be due to a lack of an enzyme, again, just like that digestive error, though this time it could be due to a lack of a hormone or the inefficiency of a hormone. When you start looking at things like diabetes, whether it's type 1 or type 2, it's a metabolic disorder. So again, there's a lot of potential for error. if you look at the system, the system being the human body, it's amazing to me that we can take in pretty much any type of food substance. Our body breaks it down and it actually utilizes the nutrients that's found within it. Now, what we cannot expect is that everyone is going to do this perfectly, perfect as designed. And we're certainly not going to do it all the same. So again, if you look at those components of digestion, if you look at metabolism, there's going to be nuances, there's going to be those potential for errors. Therefore, when it comes to what is best for a person to eat, it's always going to have to meet them where they are. It's always going to have to be an individualized approach, okay? Because everyone's going to be different. So I'm going to come back to the beginning and looking at kind of what that food substance is, what potentially a person is eating. So what you've got in front of you is a peanut butter and banana sandwich, right? You've got three main components here. And if able, you can throw it in the chat. What do you think this food substance provides the human body with? If you were to eat this, what do you think you're going to get out of it? You can throw it in the chat, and if it's easier for you to just mic up, throw your mic on, you can do that too. Good deal. Yeah. I mean, it's a variety of different things. Obviously, some of the main stuff that's typically going to come out of a peanut butter banana sandwich. Bananas, typically people are always thinking of potassium, right? But you've got some carbohydrates, you certainly got some protein as well. But each of those components, again, are giving different things to the body. Now, if you start to change some of those food items, though, the nutrient panels are certainly going to change. If I change the type of bread, the type of carbohydrate I get, what vitamins and minerals I get, and certainly the amount of fiber that's present is going to change. If I change that peanut butter to an almond butter or sunflower butter, I'm going to start to change the nutrients that's given. And then for a banana is a banana, but it does matter the ripeness of that banana. As you go from that green, yellow to more of a brown, there's going to be an increase in fruit sugars, an increase in fructose, and that's typically why that browner banana is significantly more sweet than those yellow or green bananas. Okay? But again, that's what this particular food substance is giving the body. So it calls for just a quick look at those nutrient classifications. In looking at various food substances, what's the body giving, or what's it giving the body? Is it providing carbohydrates, proteins, fats, vitamins, minerals, water? That's going to be kind of your main six. And then you have some things that are termed non-nutrient substances like fiber, which is technically still a carbohydrate, but fiber is actually something that's usually studied on its own in the research or in combination with other nutrients. So it's kind of a bit more of an utmost importance. So typically it's just categorized in that non-nutrient substance category. So I'm just going to mention a couple of things with some of these main nutrients. When looking at carbohydrates, the big thing to mention is that carbohydrates are not created equal. Okay. And I mention this because, as we know, the media portrays carbohydrates for the most part as being something people should avoid, or cut carbs, eliminate carbs. It's not that carbs are bad, and I hate to call any type of food bad. It's not that carbs are causing an issue. It's really the type of carbohydrates that are being consumed. Because again, there's a significant difference from, a fruit or vegetable whole grain carbohydrate versus a refined, processed, sugar-sweetened beverage type of carbohydrate. There's a difference. The nutrient quality and quantity is going to be different. So the issue when it comes to carbohydrates really is the fact that for most Americans, we're not consuming the right kind of carbohydrates. We're consuming more of a lower quality carbohydrate where we're really just missing out on all the added benefit of a more complex carbohydrate. We're missing out on a bunch of different vitamins, minerals. We're missing out on antioxidants, phytochemicals. We're getting less nutrients because of the carbohydrates we're selecting. When looking at carbohydrates, for the most part, it's typically going to be broken down into what we call monosaccharides. And the most commonly known monosaccharide is going to be glucose. Okay. At some point in time, the body's going to utilize glucose for fuel to some extent. And the body does it so often that there's just a constant supply of blood sugar or blood glucose, floating throughout the system. And that's a person's blood sugar. So that when the body needs energy, it just taps into what's in the bloodstream to convert that glucose into ATP so that the body has energy. But those levels of what's available, that homeostasis of someone's blood sugar is maintained by two different hormones. Both of them are coming from the pancreas. Okay? And the job, again, is to maintain that homeostasis in that when a person's blood sugar starts to rise, the pancreas gets alerted, kicks out insulin. Insulin's going to come down and basically knock on the cell of muscle tissue or the liver and say, hey, can you take some of this glucose out of the bloodstream and store it as glycogen? And in a relatively healthy individual, insulin's going to do its job. It's going to successfully get glucose out of the bloodstream and have it stored so that those levels start to come back down. Now, on the opposite end of that, when those levels start to get too low, the pancreas gets alerted again as well. But this time it sends out glucagon, and glucagon is going to go back to the muscle, to the liver, and say, hey, can you actually break that glycogen down, and can you give it back? Because we need to dump some glucose into the bloodstream. So again, when those two hormones are able to do their job, that nice little ebb and flow, it's maintained relatively nicely. But when you start throwing in potential metabolic conditions, a lot of complications can arise, especially when that homeostasis is not maintained. And that's when you're looking at things like diabetes. So your type 1 or your type 2 diabetics, where for your type 1 diabetic, they may not be producing insulin. Or for your type 1 diabetic, they're not producing. Okay? Or it's being attacked by the immune system. The beta cells that produce it are being attacked by the immune system. Or it could be type 2, where insulin's there, it's knocking on the door, but the cells aren't responding. They're not letting insulin do its job, so that glucose is getting stuck in the bloodstream. So those are kind of your instances of hyperglycemia. However, clinically, what we really need to be more aware of is hypoglycemia. Okay, those situations where those glucose levels fall below a safe threshold. And that's most commonly going to happen because of poor management of diabetes, where that patient or that client, could be taking too much insulin. They could be not eating enough, or they're participating in too strenuous of an activity. So you've got various symptoms, as you see in front of you, for hypoglycemia. But clinically, we really need to be way ahead of this, in that we need to be talking to our patients, especially those that are pre-diabetic, certainly those that are diagnosed with diabetes and medically managing it. What medications are you taking? Have you taken your medication before you came into the clinic today? And have you had anything to eat? Because if you get that diabetic who wakes up in the morning and they take their medication and they don't eat, for many medications, the job is to help lower their blood sugar. So if they start to lower their blood sugar, they don't eat anything, they come into the clinic and they participate in some type of activity, the body starts to tap into those glucose stores in the bloodstream, and that level just starts to gradually come down. And that's when that hypoglycemic episode could potentially come from. So it's having that conversation. Okay, have you taken your medication? Have you had anything to eat? And then having that situation where you've got some type of snack or something on hand that you could provide a patient to, that you could provide to a patient, okay, just to help alleviate encroaching on any of those types of signs and symptoms. So that's carbohydrates. Next, you've got protein as your next main nutrient. The thing about protein, for a lot of people, they always think protein, I need it because I've got to build muscle mass with it. That's what protein does. Well, yeah, it does. But protein actually does a lot of other stuff within the body as well. If you think of the chemical makeup of enzymes, antibodies, hormones, they're all protein based, right? The cellular structure is made up of various amino acids. So yes, protein is helping aid in building muscle mass, et cetera. It can also be used as energy, but because of all the other versatile function of a protein, the body doesn't really want to use it for energy. It wants to use it for all those other important jobs. And in cases that a person does not get enough energy, the body's going to start to break down that protein to access those amino acids. And that's really going to be its primary. So when looking at protein, the biggest thing to note is knowing, what's recommended, what's enough. General recommendation for general population has always been 0.8 to 1 grams per kilogram of body weight. It's always kind of been, I guess, somewhat of a gold standard. And to be honest, in looking at that recommendation and looking at the research, that number is way too low. Especially in dealing with the patients and clients that we're likely working with, it's far too low of a protein recommendation. So if you look at some of these population examples, you're going to see that those protein recommendations jump up pretty significantly. With your older adults, that 1.2 gram per kilogram recommendation, that's for maintenance. That's for them to maintain the skeletal muscle that they've got so that they don't lose any muscle or any strength that's associated with it. If you start working with individuals that you're actually trying to build strength, I would say is pretty much a lot of people that we're working with. But we know that in order to build strength, we've got to increase the number of muscle fibers. Well, to do that, you've got to give the body enough protein. So if you're really looking at building muscle mass, your protein intake needs to be close to that 2.0, 2.2 grams per kilogram of body weight. Okay? And I would say for anyone that's trying to improve or facilitate strength gains, really need to be getting enough protein. Now, the other interesting thing, and that a lot of clinicians are likely not thinking about, is when our patient or client is undergoing some type of metabolic stress, right? Where essentially the system, their internal engine is running high, okay? It could be some type of acute diagnosis. It could be a chronic condition or acute on chronic. Could be a brief hospitalization. Could be some type of outpatient surgery, inpatient surgery. Doesn't matter. When the body enters into that recovery phase and the engine starts running higher, the needs are going to increase. The energy needs are going to increase. The protein needs are certainly going to increase. And those needs and what's recommended in front of you as far as mild and moderate metabolic stress, that's for maintenance, okay? So if you've got that patient who just went in and had a hip replacement and they're relatively sedentary for a week or two afterwards, right, their protein intake still needs to be up at that 1.5 to 2.0 so that they do not lose any muscle mass that they have that comes with that sedentary lifestyle, even if it's brief, even if it's at 1 or 2 weeks, that protein intake needs to be elevated because of the metabolic stress that's present. Okay. In looking at protein intake, there's some pretty solid evidence that looks at distribution of protein throughout the day. And what that is really facilitating is improved muscle protein synthesis. meaning the body is more efficient at breaking down muscle and building new muscle when the protein is kind of fed to the muscle tissue throughout the day. It's got really nothing to do with the body's inability to sit down and process a large amount of protein at once. It's the evidence that looks at muscle protein synthesis. Okay, and that's why the recommendation is to distribute it across the day. There's also other emphasis of lately to look at plant sources. Okay, so likely something you've heard of relatively a lot now, plant-based proteins, plant-based foods, etc. But when you're looking at your plant-based proteins, I think the biggest push or the biggest benefit to that is when you consume a plant-based protein, you're getting all this other added benefit. You're getting more vitamins and minerals, you're getting antioxidants, phytochemicals, you're getting a lot of extra benefit than you do with the consumption of the animal protein. However, there is found to be a trade-off in that the bioavailability could potentially be different. And some of this evidence has been coming out of athletic populations, so looking at athletes, in that the consumption of animal proteins versus your plant proteins, the bioavailability for them is different, in that they have to consume more plant proteins to equate the amino acid intake as an animal protein. So something interesting, and certainly just to kind of be aware of, but again, it's the added benefit with the plant protein. After you've got proteins, you've got fats. This is just kind of a breakdown for nomenclature. The biggest thing to note with fats, it's going to be a primary energy provider for the body. Okay, as we rest and even as we do light to moderate activities, the body is going to primarily be utilizing fat to do so. And it's going to be breaking down triglycerides and throwing fatty acids into beta oxidation. It's just a different metabolic pathway and how the body produces energy. Okay, so you can think back to early biology 101 and the Krebs cycle if you want to. Certainly something you probably don't ever want to memorize again if you had to, but again, it's one of those metabolic pathways. But for fat, again, the primary thing is energy. So as you've seen, carbohydrates, proteins, fats, they can all be utilized for energy. They all each have this metabolic pathway that can be utilized in order to produce ATP. Alcohol can do it as well. Okay, there's a different pathway to do so. So those are your three main energy yielding nutrients, and then your other main nutrients being vitamins, minerals, and water. For time's sake, I'm not going to jump into these. I'm going to give you a resource that you can dive into in case you've got any questions, or if you've got patients or clients that have questions about various vitamins and minerals. But just know that every vitamin and mineral within the body, it has its own role. It plays its own part. So we have to make sure we're getting an adequate amount of each of them so that its roles and duties can be carried out. And then those non-nutrient substances, fiber is pretty important. Typically, fiber is categorized as soluble and insoluble. But what they've done recently within your soluble fibers, they've actually started categorizing that as viscous or fermentable. They're both soluble, but they do two totally different things. Okay, your viscous fibers most commonly are going to decrease the diffusion rate of some cholesterols, but more importantly, decreasing the diffusion rate of glucose, meaning that with the consumption of a good quality carbohydrate, a complex carbohydrate, when the fiber is present, it blocks glucose from passing quickly into the bloodstream. And so that's why you don't get a rapid spike, when you're consuming a complex carbohydrate versus something that may be refined or even a simple sugar. Phytochemicals, antioxidants, and then additives. For some additives, sometimes get a bad rap. It's not, it makes the food not whole or unnatural, etc. But an additive could be a food substance that is enriched or fortified, okay, which could potentially provide a lot of good quality nutrients to an individual. If you look at fortified breakfast cereals that are fortified with vitamin B12 or iron, those things aren't naturally in there. But if you've got a person that has difficulty consuming B12, especially those following a vegan or vegetarian pattern, it's a pretty easy win for them, right? Don't really have to take a supplement. You just have to consume a food item that's fortified with that nutrient. So that is still considered an additive, but again, there is a benefit to some of them. These are the resources I was mentioning. If you've got the PDF handouts, these should be clickable. The first one is an interactive tool where you can just plug in a basic height, weight, age, gender, activity level, and it'll spit out kind of general recommendations for nutrient intake. The next one is actually probably my favorite resource because it's consumer fact sheets from the NIH, and it's consumer fact sheets on literally anything: vitamins, minerals, herbs, spices, supplements, what have you. So if you've got a patient that's wanting more information on calcium, there's a fact sheet for it. Right? What is calcium? What's it do? What's recommended based on age, population, etc. What foods provide calcium? How much calcium does X amount of food provide? So like I said, fact sheets for everything. Okay. Acai, berry, ginseng, whatever random thing you've got a client asking about, there's probably a fact sheet for it. So pretty solid resource. And then that last one is a labels database for any type of supplement. It's a new database from the NIH that actually released earlier this year. But it's basically, if you search any type of supplement, it should be able to pull the label. It'll give you a detailed ingredient list as available. So relatively new, but a pretty decent resource. So as I spoke on earlier, and still looking at that science of nutrition, we briefly kind of looked at the consumption, digestion, metabolism, kind of utilization of those nutrients, what some of those nutrients look like. But remember, there are all these things that actually impact what a person picks up and selects to eat, or what they have access to eat. And that's what these determinants of healthy eating are. So they're going to be either personal or environmental. But if you look, these are potentially the underlying barriers or reasons as to why a person may not eat what's deemed to be healthy, right? What's kind of that picture perfect healthy plate. Why they may not be doing it could be potential to a personal or environmental factor. So, just to kind of rattle off a few, if you look at your personal, it could be beliefs, it could be knowledge. It could be lack of skill in preparing certain foods. It could be how they look or taste. Those type of things, if you don't like the way that broccoli tastes, or you don't like the way that a certain food looks, you're probably not going to eat it. So it's affecting the foods that you select. The oral health is on there, kind of as mentioned earlier. If somebody's got difficulty chewing something, they're likely not going to eat it. Okay. And then there's functional mobility status. And this is really something I'm trying to get physical therapists to understand, but certainly applicable to our occupational therapists and other exercise professionals, is how people move and their ability to move affects their nutritional status. If you've got that person who has difficulty standing for long periods of time, standing unsupported, standing with the ability to use both of their upper extremities, how does that affect their cooking? How does that affect their ability to prepare a meal? If you've got a person that has difficulty going up and down steps or walking longer distances, how are they potentially going to leave their house? How are they going to go to the grocery store? How are they going to bring food back? So how that person moves is going to affect the access they have to food, okay, which could potentially affect their nutritional status. So we're in this, right? When it comes to what a person eats, again, that functional mobility status is going to be a significant determinant for a lot of people. And then you've got environmental factors. Where does this person live? What's the food cost look like? What type of policies are in place? What resources are available? That's going to affect what that person has access to and potentially what they select to eat. Okay. So if you look at some of these personal ones, there are a lot of ones here that certainly modifiable from a PT standpoint, certainly modifiable from an OT standpoint. A lot of it has to do with education, behavior change. And then on that environmental side, it's really advocating, right? What resources are available in your community? Okay? And how can you kind of rise up and kind of advocate for patients and other members in that community? So that's kind of the basics of nutrition, really trying, again, cram in a lot. But that's the basics. And then we'll jump into next is really more of its applicability. But before that, any questions for those of you that are with us?
So my only question that I have so far, which you'll probably address in your next session, is how, just based on like our scope of practice, how in depth you get when you're doing your education versus then referring out to a dietitian specifically.
Yeah, I'll get to it.
Okay.
Yeah. It's a good question. It's always a number one question, but no, I'll cover it. Minnesota is, I will tell you, it's a bit unique. And there's a part of statutes that are difficult for me to interpret because I've not encountered it before, but we'll get to it. And then maybe even knows the answer, but yeah, we'll cover it. Awesome. So in looking at nutrition, nutrition is not a toolbox item. And this is something, it's a term commonly used within the PT profession, so likely also used in other healthcare professions as well. But it's skills and techniques, that we learn, we'll put in our toolbox or hang on our tool belt. And, hopefully when necessary, we utilize it with the appropriate patient. Nutrition is not one of those things. Nutrition really needs to be seen as more of an integral part of patient-centered care. Regardless of the patients that you're treating, regardless of the setting you're in, it's likely going to affect that person. It's going to affect their health outcomes, their rehab outcomes, their general health goals, personal goals, etc. So it's got to be something we need to be thinking about. Will you address nutrition with every person that you encounter? Probably not, because you may have decent conversations or you may find people who are eating well, and that's totally fine. But it is, again, something we need to be thinking about at all times. So just to kind of give a little bit of relevancy to it, this is something I typically do when educating physical therapists, but certainly applicable in looking at our OTs and other exercise professionals as well. But nutrition's important, okay? If you can look at the health of the muscle tissue, we're dealing with patients that have a diagnosis of muscle weakness and we're trying to get them stronger. There comes that protein need. Okay? There comes that increase in protein need if they're trying to build muscle mass. So there potentially is that need to have that conversation. Or to the opposite effect in trying to maintain a person's skeletal muscle mass to prevent sarcopenia and to prevent everything that comes after that. Osteoporosis, bone health. You could be dealing with a patient or client that is diagnosed with osteoporosis, osteopenia, but it could be someone that's recovering from some type of fracture or recovering from some type of orthopedic surgery that involves their bone tissue. It's not just calcium and vitamin D. There are other nutrients that drive bone breakdown and bone buildup. Okay, so making sure that we're having conversations around those other nutrients. Yes, calcium and vitamin D are important, but we have to start looking at other nutrients, especially in dealing with those patients who are recovering from any type of fracture or orthopedic surgery. Just as with, again, healing, if the engine's revved up, okay, if that person's being hospitalized for something, if that person is just getting out of surgery or even prepping for surgery in a pre-op situation, there's going to be increased protein needs. There's going to be increased caloric needs because the system is running higher, the engine's running hotter. You've got to feed it. You've got to give more calories. You've got to give more protein. Okay. Same thing in dealing with pressure injuries, same thing with dealing with any type of skin condition. You've got to give the body the nutrients that it needs. If you look at diabetes, it's likely more prevalent down where I am, living in the diabetic belt in the South, but we know diabetes is prevalent across the whole country. And if you look at the condition, the pathology of it, right, it's not good if it's not managed well. You've got effects on healing, but you've got effects on nerve conduction, sensation, all that stuff. So why not have that conversation? A couple other patient diagnoses you may see, congestive heart failure. There may come a point where they're on some type of fluid restriction. So it's having that conversation of, promoting hydration because of the importance of water, but kind of towing that fine line of not overloading the system and going beyond what those restrictions for that person may be. Patients with COPD, again, I'm working more with geriatric populations, so I see these patients more often. But what a lot of people don't know in that general recommendations for patients with COPD, there's actually an increased caloric need. So the recommendation for that patient population is to intake more calories. And it's because the system is working harder to breathe. And with that excess work, the body's burning more calories. Okay. Again, it comes down to that individual and other effects of their metabolism, but general recommendation for those patients is actually increased caloric need. Pain management. This has kind of been an interesting one lately. Obviously, if you look at the physical therapy profession and the Choose PT campaign and our fight against the opioid epidemic, pain management is important. There is a potential link, and some of this information is typically found in isolation in that it has to do with inflammatory markers. In that they look at inflammatory markers of patients that are reporting chronic pain. And there are certain inflammatory markers that are elevated. It's most commonly interleukin-6, okay? And then they look at patients or individuals that are consuming more of an inflammatory eating pattern, right? They're consuming a lot of processed foods, a lot of sugar, a lot of red meat. And their inflammatory markers are also elevated, most notably being interleukin-6. So there's something going on, right? That chronic pain is increasing inflammation. You've got intake of processed or inflammatory foods increasing inflammation. There's nothing out there, of course, that says if you eat a donut, your back pain gets worse, right? That's not there. Okay, there's some type of tie. There was a study that came out, it was the beginning of 2019, that looked at spinal pain. And it was a patient population, it was a sample size of people complaining of chronic low back pain. And when they improved their eating pattern over time, they did report reduced symptomology of their spinal pain. Okay, so there's something, right? It's not 100%. But there is something, especially looking at that inflammation. You can look at other conditions like rheumatoid arthritis. There is recommendations for nutrient intake in terms of an anti-inflammatory pattern for individuals with rheumatoid arthritis, in that when they consume that healthier pattern, the progression and severity of their condition is less. So there's definitely something going on, just really something to be mindful of. Could be dealing with patient population in terms of athletes, and knowing that based on their sport or activity or their goals, their nutrient intake is going to differ. That sprinter versus that power lifter, their nutrient needs are going to be different. Okay, because their goals are different. What they need is going to be different. And then the other thing you've got to kind of look out for is any type of risk of eating disorder. Okay, especially dealing with high school or collegiate athletes, being aware and mindful of that risk. And there's a screening tool I'll show you in a bit that you can use with that patient population. And then you've got individuals who are pregnant or even trying to conceive. You may be seeing them for something in relation to their pregnancy or outside of it, but just know that that mother has specific nutrient needs. Okay? Whether it is preconception, during pregnancy, and even postpartum, there are recommendations, specific recommendations that carry through. So outside of some of those, if you just look at the general health of an individual, nutrition is likely going to affect them there as well, because nutrition and nutritional intake in and of itself is a risk factor for many chronic lifestyle diseases. And then the funny thing with chronic lifestyle diseases and metabolic conditions is there's evidence that looks at some metabolic conditions can actually increase the severity and prevalence of a musculoskeletal condition. Right? Like there's data that looks at and supports hypertension being a risk factor in and of itself for occurrence and severity of rotator cuff tears. Right? There's something going on. Okay, and a lot of it has to do with inflammation and within the system that puts strain on ligamentous tendon muscle tissue. But there's a tie between. Right? So why not get ahead of this? Why not have the conversation to this point, try and reduce risk and eliminate or potentially reduce the risk of some musculoskeletal conditions. It changes the conversation. You could be dealing with patient populations that are at risk of being malnourished as well. When some people think about malnourishment, they automatically go to the older adult. Right? Only an older adult can be malnourished. Well, that's not true at all. Because if you look at the risk factors of malnutrition, those things can happen to any of the clients or patients that we serve. If you think of it from a PT/OT perspective, patients we might be seeing, well, they could have had some type of CBA, TBI, right? Could be effects to chewing or swallowing. Could be just coming out of the hospital, so might be taking a bunch of different medications. Could now be dealing with financial hardship. Could be dealing with cognitive deficits or effects to that nature. You've certainly got increased metabolic needs. Doesn't matter in terms of it just being older adults, right? It can affect anyone. You take that person who's post-op. You take that middle-aged individual that just had an ACL reconstruction surgery, not sitting well after anesthesia, not eating enough, not getting enough protein, potentially out of work for an extended period of time. All those risk factors are all the same. So kind of, again, being mindful of that. And I've got some screener tools that look at malnutrition coming up. So again, in looking at how it's relevant to your patients and your clients, in terms of us as PTs and OTs, you can link it directly to those movement components. Or you can link it to, that risk of malnutrition or chronic disease. But ultimately, nutrition is going to potentially affect their rehab outcomes, their health outcomes, and potentially their personal goals as well. Any questions to that effect? So we got our common question. Is nutrition even within our scope? And this again is it's the most common question that I get, and rightfully so. And the, you know, one of the disadvantages within, the physical therapy education, and then likely also within occupational therapy education, is nutrition is, for many curriculums, it's not there, or it's there in the sense of meeting this tiny accreditation requirement that says the word nutrition. So whatever they talk about within digestion, metabolism, utilization, if they just talk about one of those little components, it meets that. But do they talk about actual implementation into practice? No. Right? So if it's not in the education, that's why it's that common question. Right? Is it in our scope? What can we actually do? So within the field of physical therapy, there was a House statement that actually originated back in 2015. And it's a positional statement from APTA's House of Delegates that indicates, nutrition and diet to be a part of our professional scope of practice. And that it's within our professional scope to screen for and provide information to patients, clients, and the community. Now, the language was updated in 2019, and that's the latter half that's bold. And it includes consultation, co-management with, or referral specifically to a registered dietitian. Excuse me. That being when the needs exceed what that provider can give to a patient. When it precedes their professional scope, and this clause is an instance of their state statutes, which we'll get to, but also their personal scope of practice, right? What's your own training and education look like? As a clinician, did you take additional coursework during your undergrad on nutrition? Is your undergrad degree in nutrition or nutritional sciences? Did you take extra continuing education, et cetera? That's a part of your personal scope. But this is, again, support from the APTA that, yes, it is within our professional scope of practice. But again, there's also layers to that we'll look at. When the association updated things back in 2019, they gave themselves a position as well, and that the organization as a whole supports collaboration between PTs and RDs. I would say to this extent right now, the biggest collaboration and relationship I know of that's happening is between the Academy of Geriatrics Physical Therapy and the Healthy Aging Dietetic Practice Group. Which is basically the geriatric section of the dietetics world within the Academy of Nutrition and Dietetics. Those two entities have been collaborating. I think they've got like a 4-part webinar series they're working on. So there's definitely stuff that's started happening since this statement was released, which is awesome. On the occupational therapy side, there's no specific language to nutrition. As we have within the physical therapy side. But as you can see in some of their language, this being a role of the occupational therapy in health promotion, you can see, as an example, establishing daily meal intake schedules for proper nutrition, addressing barriers to meal planning and shopping, creating strategies for managing food choices. It's promoted, it's advocated for within that profession. So that's kind of the big two big ones. Again, there's a lot of gray, and we'll get to that a little bit more within that considering a professional practice acts, right? There's a lot of gray in that there's no language that says you cannot do X, Y, and Z, right? Within the PT and OT side. Okay, but we're going to look at the dietetic statutes and stuff too. But again, Minnesota, things get a little weird because of, what's it called? I'll get to it. I can't remember. It's some type of contemporary medicine statute. So what I like to do with clinicians is look at steps to identifying that intervention. Essentially, you've got that patient that comes to you. You should be able to kind of roll through these steps relatively quickly to determine, is there a need? Can I address it? And if I'm going to address it, what is it that I'm going to do? So that starts with performing some type of nutritional screen. I really think this needs to be a minimal requirement. What's their nutritional intake look like? Is it going to facilitate their goals? Is it going to prevent recovery? We don't know unless you ask the questions. You don't know until you screen for their nutritional intake. The beauty about nutritional screening, though, is that it can be done at any point in time. For some, it's easy to kind of use a standardized screening tool, throw it into that initial intake form. That's totally fine. But it can really be done at any point during that plan of care. And what I most lately have been advocating for is don't do it on day one. Build that relationship, build that rapport. Okay? Because nutrition, as you saw in looking at those determinants of healthy eating, nutrition is very personal to people. So until you build that relationship, until you build that trust with that person, you're likely not going to get the real answer. You're likely not going to get the true barrier that could be preventing them from eating healthier until you build that relationship. Because we know most patients, we ask them something, they're likely going to just tell us what we want to hear. We've all lived that. But until you have that relationship, they may not open up. So again, if you want to do it at the beginning, totally fine. It's the intention. If you don't do it on day one, it's after you feel that a relationship is established that you certainly start screening and having that conversation. When it comes to screening, there's a couple different tools that you can use. So these are a couple different examples. All of these that you see in front of you, if you just did a Google Scholar search of them, they're an easy pull with a full PDF access. Okay, so that's why these are listed here, because they're easy to get a hold of. But most of them, they're just food frequency questionnaires. How much of X, Y, and Z do you consume on average? How many servings of fruits and vegetables? How often are you eating processed food? How often do you eat out? And what it does is it really just paints a picture. Okay? What do they eat day to day on average? So you can use a screening tool, or you can just have a conversation. Gather a food log, get a 24-hour recall or a 3-day food log, get a general understanding of what they're eating. The more you do it and the more often you look at that type of information, you're able to say, okay, quality carbohydrates, decent amount of protein intake throughout the day. Generally looking at portion sizes, I'd say you're probably getting maybe 75 grams. The more you do it, right, the easier that gets. But that's how you can screen. The other tool I mentioned earlier with the eating disorders, the Eat26, is a good one. Again, if you're working with that population that is potentially at risk for eating disorders, most commonly going to be high school collegiate athletes, but as we know, really anyone. So if you've got concerns with that, that's going to be one of your go-tos. In terms of malnutrition, again, if you search any of these within Google Scholar search, you'll be able to pull up the full PDF or the full form. But for malnutrition screening, it's just screening those risk factors. Okay, how's your appetite? Have you had any unintentional weight loss? How much unintentional weight loss? Are you taking multiple medications? Have you had effect to your functional mobility status? Have you been bedridden recently? So it's going to start pulling those type of questions. For many, and what's starting the most, the mini nutrition assessment short form is the one that's been found to be the best in dealing with community members. So kind of your community dwelling population, that is the recommended one to utilize as identifying that risk of malnutrition. Outside of that, there are characteristics. The interesting thing about malnutrition, and really the difficult thing about malnutrition, is there's no gold standard in diagnosis, right? There's no blood test that says, oh, you're malnourished. They used to think looking at albumin and pre-albumin levels would be an indicator, but it's just not accurate. So there's no real gold standard. So outside of those screeners, there are these characteristics. And what they've decided is if there's a presence of 2 or more, the person is potentially at risk of being malnourished. Now, if you look at some of these characteristics and you think to yourself, as a PT, as an OT, as an exercise specialist and certainly as an RD as well, we can likely identify normal versus abnormal muscle tissue, fat tissue, identify the presence of edema, and grab a dynamometer and take a hand grip strength and compare it to standardized data. That stuff, especially as PTs and OTs, that's in our wheelhouse. So then it only comes down to, how's your appetite been recently? And have you had any unintentional weight loss in the past 3 months, 6 months? And you just screen for malnutrition, right? Easy. It's just thinking about all these things that we potentially see in different points or at different points in time and putting it together. So malnutrition, again, I think is an easy one to be screening for. There are a couple different informal nutritional screens as well. Some of this stuff is more advantageous if you're doing home health or even telehealth, where you're able to see the environment. How are they storing food? How are they preparing food? What's that look like? Can they safely heat and store? How are they doing physically within that environment? How are they doing cognitively within that environment? Because if they're having difficulty, or if they don't have the right equipment, then that nutritional status is going to be impacted. So that's screening. A couple different ways to screen, but again, you're essentially identifying, is there a need? Now, within that screen, you could find out that, well, Mr. Jones is eating great. Provide some positive reinforcement. Hey, Mr. Jones, I think what you're eating day to day is really going to facilitate good recovery. I think your hip, after that hip replacement, I think we're going to get you stronger and get you back to where you were before in no time. And I think your nutritional intake is going to fuel that. Done. Positive reinforcement and move on. Now, let's say you identify that there is a need. Right? They're not eating the most appropriate pattern, or they're not getting enough of X, Y, and Z. You've got to look at that patient's medical history. And you've really got to determine at this point, is this patient going to more so benefit from seeing a registered dietitian? In that, are they going to more benefit from having medical nutrition therapy? In that, is their nutritional need directly influencing a medical diagnosis? Do they need to consume X, Y, and Z of an exact quantity to treat some type of medical condition? That's medical nutrition therapy. If it's general education for healthier intake, it's okay. But if you find that that education and information you're sharing is treating a medical condition that they have, that's when you've crossed that professional boundary. That's when that registered dietitian should be having that conversation or setting up some type of collaborative co-management approach if that education behavior change is targeting a medical diagnosis. If it's just for general healthy intake, it's okay. For the most part, again, you've still got to look at those professional practice acts. But medically, you've got to determine what's best for this patient. So that's when you're looking at those steps. Again, there's a need. Medically, nothing going on. You've got to look at those professional practice acts next. Because if there is something going on medically, you would refer prior to knowing what you can do as a individual clinician. So looking at professional practice acts, you've got to look at physical therapy, occupational therapy, whatever other profession you may be licensed as, but then you've got to look at dietetics and nutrition. Within the PT world, which I'm more familiar with, there's no language that states anything specific to diet and nutrition. Okay, there's no physical therapy practice act, that has diet and nutrition written in it at all. A couple exceptions. North Carolina's licensing board has a statement that says supplementation is not a part of physical therapy practice, meaning in the state of North Carolina, you cannot talk about supplements, educate on supplements, etc., because the licensing board prevents it. The state of Illinois, their chapter has a positional statement for nutrition, very similar to APTA's. But outside of that, across the country on a PT side, it's not mentioned. It gets super gray, right? But there's nothing saying that you cannot implement it. But you've got to look at the dietetics and nutrition laws. And you've got to ask yourself two main questions. Are there title protections? And is there practice exclusivity with possible exemptions? So if you look at physical therapy statutes for Minnesota, I underlined some things as far as what physical therapy means. Again, there's nothing in the statute that says it is not a part of practice. You have some language that you can certainly tie in nutrition to, as far as preventing, alleviating physical, mental disabilities, consultative services, education, etc. So kind of a tie-in, but again, no language that is preventative. If you look at occupational therapy and their scope of practice, again, looking at what is the practice of occupational therapy, okay? Health promotion and wellness, consultation. You start looking at things within their language. There's some stuff that you can definitely tie in nutritional intake. Again, there's nothing in there that says it is not a part of practice. So again, what you've got to look at is the Dietetics and Nutrition Practice Acts. Every state across the country is vastly different. That's what makes it so difficult to mass educate all physical therapists, occupational therapists. Here's what you can do as a clinician. Yes, for the most part, we should all be screening. We should all be providing general basic education. But beyond that is where things get a little gray because it's going to differ state to state. So you've got to look at those individual state practice acts. Every state is going to identify, dietetics or nutrition care services, assessment, counseling, relatively the same. Some states drastically different, but this is how the state of Minnesota outlines these particular terms. Okay, and for time's sake, if you want, you can go back and kind of look at them. But what you've got to recognize is that for licensure, there are two licensure pathways in the state of Minnesota. And that's to obtain a dietitian title or a nutritionist title. So the dietitian title is via the RD pathway, okay? And that you've got to have certain undergraduate content, you've got to do a dietetic internship and sit for the RD exam. Okay, so that's a pathway that I took. So that's the RD pathway. But there's also a nutritionist pathway in that a person can hold a master's or doctorate degree in some sort of nutrition topic, or they go the route of a certified nutrition specialist, which is a certain type of criteria that have to be met. It's like 12 graduate credits, 900 supervised hours, and their own version of a board exam. So again, it's just two different licensure pathways. But there's also in the state of Minnesota a third that kind of comes in by petition, where if a person holds a certain degree, if they get some supervised hours, they can petition to not take one of those national examinations. So that's how you can become licensed. Now, within a license requirement, this is where you're going to find your title protections and your practice exclusivity, okay? So no person may engage in dietetics or nutrition practice unless they're licensed. That's a practice exclusivity clause. So what is dietetics and nutrition practice? Well, you've got to go back to your definition. What is included? Well, within that, you've got the provision of nutrition care services. Well, what is that? Oh, it's an assessment. What's that? Counseling. What's that? Right? So that's your practice exclusivity. You've also got title protections for dietitian, nutritionist, etc., meaning that a person has to be licensed in the state to call themselves as such. which is nice because you know who you can partner with. You know that if you're talking to a dietitian, they're licensed. You know that if you're talking to a nutritionist within the state, they've attained licensure. Not every state title protects the same thing. You can come to South Carolina, a nutritionist is not a title, is not a protected title, meaning anybody can call themselves a nutritionist. You could go to another state like Arizona that doesn't even have laws and do whatever you want. So it matters what the state statutes read. Okay. So again, Minnesota's got practice exclusivity and title protections. But when a state has practice exclusivity, you've got to look to see if there are any exemptions. Within the state of Minnesota, you've got exemptions. But if you look at these exemptions, we're not popping out as we would in some states. Okay. So if you're licensed to practice medicine, nursing, et cetera, you're exempt. Okay, meaning as long as you don't call yourself a dietitian or nutritionist, you can engage in some of those nutrition care services. If you're providing some type of weight controlled service, and this is an exemption that's pretty prevalent across the country, that you can administer these programs as long as you don't call yourself a registered dietitian. But if you change the program, somebody licensed has to do it. You're exempt if you are furnishing nutrition information as far as marketing and distributing products. Okay, then you're exempt from any type of practice exclusivity. If you are a person who's recognized in the community as a provider of nutritional advice, okay, including a medicine man or woman, and you advise people according to or based on traditional practices, and you don't call yourself a dietitian or a nutritionist, then you're exempt. So this is where things get a little bit gray. And then if you're a person who provides nutrition services without being paid to family members, let's say you want to counsel or educate a family member on improving their nutritional intake. As long as they're not paying you for it, doesn't matter. So these are a couple of the exemptions I picked out. There are others that are in the statute, okay? But it gets kind of gray. That number 9 is what makes it gray. But then also this complementary and alternative healthcare practices makes it a little gray as well. We're not going to have time to stick on it, but something to kind of look at. And I don't know, Eva, if you are able to interpret this better than I, but it's weird because I've never seen it, to be 100% honest. But if you are considered to be providing complementary alternative healthcare practices, things get gray, right? But then there's the unlicensed component to it, where if you're unlicensed, but then this is where I was having a hard time determining whether or not physical therapists or occupational therapists were considered licensed healthcare providers in the state of Minnesota. So that was a challenging component to it. But even with the practice exclusivity that the state has, you can still certainly screen for nutritional needs, educate on those basics, okay? But because of the design of the company that you're working for, you've got the dietitian on staff, meaning that if you feel that you're crossing professional boundaries, just have that conversation. Hey, when do you think, and based on your interpretation of the statutes, that it's crossing those professional boundaries? Okay, that's the easy part that you've got. Because realistically, when it comes to, and it's sad to say, but when it comes to crossing those professional boundaries, it's like, well, someone's reporting. Well, who's going to report crossing the boundary? It's going to be a licensed dietitian or nutritionist. But if you've got one on staff that's working with your patients, then it's not going to happen, right? Or it'd be a waste of time, to be honest. To give a different example, Kansas has practice exclusivity as well, but within their exemptions, they actually list physical therapists specifically within their exemptions to practice exclusivity. So again, every state's just vastly different. Okay. But when it comes to the basics, relatively safe and having that conversation as long as you're not treating a medical condition. And again, if you feel like you're crossing that professional line, you've got the staff member to communicate with. Right? You've got that opportunity to very easily collaborate and co-manage, whereas a lot of clinicians don't have access to that, and where things get super tricky. So coming back to this, yeah, go ahead, Eva.
Yeah, so we've talked to our legal counsel as well as our chapter, our Minnesota chapter, who's put on quite a few educational resources together for members, and both are in agreement. What we can do is, there's a statement, I was looking for it, but I can't find it right now because of course I'm not at my desk, but we can screen, we can provide education that's within our scope, and then after that, we need to refer to a dietitian. But what's interesting here in Minnesota, there are numerous people, including health coaches that don't even have a degree, but they call themselves a health coach, that also call themselves nutritionists. Their title protection is not enforced here. I don't think anyone has ever been penalized. And there are people that advertise on their websites, their social medias as nutritionists. And I mean, it's just used so loosely here with no repercussions. Like everybody under the sun, it seems like they're nutritionists. And yeah.
Because I didn't see, some states have it when they have the title protections, they have the clauses for fines and misdemeanors and stuff, but Minnesota doesn't.
It doesn't, right? So everybody under the sun just uses it. And but our acupuncturist actually does nutrition. I mean, she was listed in one of those, obviously, as an exemption, but she does nutrition consults and actually prescribes supplements. So yeah. So there's so yeah. But we've been,
I would fall under this for the most part.
and thankfully, none of us feel, I mean, it's so nice that we have Sarah on staff because we can just refer her to things, but it's also great that we also can provide a lot of education ourselves too. So, but we do fall in that gray space because we're considered somewhat we fall under that alternative medicine umbrella as well. But that we've pretty much followed the most conservative, obvious approach to this, which is what I just shared. Yeah.
Yeah, and that's probably the easiest way to go about it too, because it kind of comes into this last step as far as that professional self-reflection. What's that knowledge base of that clinician, of that practitioner? And that's really going to carry the extent of that conversation. What's that foundation knowledge base look like? Knowing to maintain evidence-based information, knowing to avoid any type of personal bias or belief, knowing that what may work for you or a family member or friends certainly is not going to be applicable to patient or client that you're working with. So yes, the basic information is always going to be the best place to start. And I've got some resources for that coming up in a second. And then that last question, what's your level of comfort? Because we know nutrition is very personal, you may have to be sensitive to some of those conversations. So just being mindful of that. So again, kind of a step to identify, what is an intervention that is possible. So going through, right out the bat, are you going to refer, collaborate, co-manage with that registered dietitian, or like you said, the acupuncturist, the other individuals on staff that are providing services? Are you going to educate? Okay, what's that look like? Well, you've got national guidelines, you've got solid publications from credible sources. How about assisting with access or facilitating behavior change? Okay. What's the intervention route going to be? And then, of course, that advocacy within your own local community. As I said, looking at that referral or collaborative partner, the registered dietitian is kind of a number one thought, especially within the realm of the physical therapy, that it's being supported by the APTA now. But you've got other options as well, that certified nutrition specialist, you've got the acupuncturist, You've got, well, because of the complementary care stuff in Minnesota, you've got some other things, but these are kind of the top ones nationally that I typically recommend. Your diabetes care education specialists, and then your physicians that are actually board certified in nutrition. In looking at nutritional education, the goal should really be to facilitate normal, healthy intake, where you're boosting metabolic efficiency to facilitate physical health, improved personal goals, improved rehab outcomes, and trying to reduce risk of developing chronic disease. It's super broad, but again, you're not trying to treat a medical condition. You're trying to just facilitate what is deemed and found to be healthy, which is obviously super relative. This particular resource, findhelp.org, is a pretty solid resource. You plug in a zip code and it pretty much tells you anything that's available within your local community. So it looks at nutrition, but it also looks at transportation, housing, everything under the sun. But in terms of nutrition, you're looking at food banks, pantries, congregate meal sites, what's the company that does Meals on Wheels, all of that information can be found within that website. So a pretty solid resource. If you do go that route of motivational interviewing or behavior change, which may get a little bit trickier in the state of Minnesota because this is beyond that education, but I do think within motivational interviewing, it's a good technique and a good process to undergo because it helps identify those underlying barriers as to why a person may not be consuming X, Y, and Z. And one of the perks of that is really determining, where that person is in a stage of change, in a readiness to change, or an importance scale. Because if they're pre-contemplative about nutrition, meaning that they don't think it's important, they don't think they need to change their eating habits, the education and the information that you provide is going to be vastly different than if that individual is in a preparation or action stage. Because if they're pre-contemplative, all you're really doing is planting a seed. What's the benefits of consuming an extra serving of fruit throughout the day? What's the benefit of trying to increase protein intake? You're just planting a seed. Versus that preparation, you're educating on potential ways to actually do it. Swap your regular yogurt for Greek yogurt. Add a tablespoon of peanut butter, right? You're getting a little bit more into the education information that you're sharing. But again, you've got to find out where that person is so that you can provide the most appropriate type of information. One thing to consider with applying and integrating it into practice, remember every individual is different. They've each got their own needs, their own determinants of healthy eating. The time and manner to address it's never going to be the same. Remember, you're likely going to want to build that relationship and that rapport before you start going down that rabbit hole, and making sure that you're meeting them where they are. So in conclusion, and I do apologize for going just a couple minutes over, nutrition is certainly essential to patient-client care for their general health, but also for rehab outcomes if that's why you're seeing them. You're not going to know if there's a nutritional need, though, unless you're screening. You certainly want to be mindful of your practice acts, but also be mindful of your own knowledge limitations and where you may need to pick up additional information. But always be sure to utilize a readiness to change scale or a readiness of importance or confidence scale, because again, that's going to really dictate what type of information you should be providing, because you honestly don't want to waste time educating or giving someone really good quality information and they're not ready for it. So making sure, again, you're meeting them where they are. And then with that education, again, trying to facilitate what's deemed to be normal, healthy intake, which in no way is treating any type of medical condition. So that's all I've got for you this evening. I do appreciate attentiveness of those of you that have been on. I'm sorry, it was a lot to cram in, and it's a super short period of time. But if you want to continue the conversation, if you've got questions, I could certainly stick around for a couple minutes. My email you've got in front of you, but in all honesty, Twitter is probably the easiest way to get a hold of me.
Awesome. Thank you, Patrick. And just a quick question. Are you, do you know of any CE that will be, or either yourself or anybody else presenting on nutrition at CSM next year?
At CSM, I am not aware of anything at CSM.
Okay, I wanted to ask you that. And then the other thing is, there any courses or certifications that you recommend for physical therapists?
So in terms of nutrition, right, there are some certifications that a couple universities do offer. They call them, they're like nutrition certifications for healthcare providers. They're graduate credit certifications. It's usually like, honestly, like 9 or 12 graduate credits, and it starts to get super pricey in that, you know, you get this certification that costs you 10 grand, but based on where you practice, it might not change anything, right?
Mhm.
So, you know, looking at Minnesota law, just if you had that certification, it's not going to change what you can do. However, the interesting caveat to that, though, is if you did one of those nutrition certifications for healthcare providers, and the ones that are coming to mind are Roseland University, Tufts, somebody else in the Northeast. Their graduate credits within their certifications meet the requirements for the certified nutrition specialist route. So then you would just have to get the 900 supervised hours and sit for boards, and then you can get licensed that pathway. Obviously, it's pricey and time consuming, and it really matters to the extent that you would want to use that information. You know, if you would ever want to go beyond that basic education, but those are like the formals that are kind of available.
Okay.
Outside of that, nothing major. I mean, there's precision nutrition. I've heard decent things. I've never looked at it myself as far as kind of, again, improving that foundational knowledge.
Mm-hmm.
But yeah, that's.
And I know, why can't I think of his name? Joe, it starts with a T.
Tata.
Yeah, Tata. I know him and Ginger have like a certification course. Do you recommend that?
I've not looked at it. I know Joe's got good stuff. So Joe's based out of California. I do know that a lot of his stuff is really focused on pain science. I think that's his emphasis. But I haven't looked at it myself personally.
Okay, just wanted
Yeah.
to know. I don't know.
Yeah.
I mean, of course, at CSM this time, it was very good. I just didn't know if you had any thoughts on his course or. Okay.
Yeah,
Thank
I haven't looked at it. I mean, I think for the most part, you know, the other route to potentially look at too, and it's all about time commitment, and there's always a financial commitment through, who is it? It's the university that's in Nevada. It's a health coaching certification. And I don't know why I can't remember the name of the university, because I did a feasibility study for them and now I can't think of it. But a health coaching certification, in all honesty, is likely a better route to go, because then you can educate on any health behavior, right? You're not just to the nutrition, but you're looking at everything.
Yeah.
So again, it depends on what, and these are conversations I always have with clinicians. It's like, what's the intention?
Mm-hmm.
What's the purpose? And then you can decide from there.
Yeah. Yeah. Helping with lifestyle changes, more knowledge. Yeah. Okay. Got it. Well, thank you. Appreciate your time today. Oh my gosh, this was great. So thank you.
Yeah, you're welcome. No worries.
Yep. Thank you. It's very interesting.
Have a good night, Patrick.
Thank
you.
you.
Have a good one. Thanks.
Bye. Bye-bye.
Bye.